Hi guys, today we'll be discussing some important topics about family planning. So, the first thing today we'll be talking about is dilatation and evacuation. If you're doing a D&E at 18 weeks gestation, and if you, while curettage, you see a piece of tubular peristaltic tissue through the cervix, what should be the immediate clinical priorities and what will be the stepwise surgical management pathway for this patient? So basically there is uterine perforation with bowel coming out from that perforation. So what should be the immediate priorities? Stop the procedure right away. Do not attempt to push the tissue back through the cervix or pull it further. Discontinue any suction or instrumentation. Stabilize the patient. Ensure adequate large bore IV access. Initiate crystalloid resuscitation and order a cross match for the blood products. Notify the anesthesia team of the emergency. Prevent any traction injury. So when you know that you're holding that forceps, if you leave it, it might pull that bowel more down. So you need to secure the forceps or the prolapsed tissue at the introitus without applying tension to prevent further mesenteric tearing or devascularization of the bowel. What will be surgical management pathways? First, access. Immediate emergency laparotomy. A midline incision is preferred for a better bowel exposure, otherwise it's going to be more struggle for the surgeon. Identify and release. Locate where the uterine perforation site is. Carefully release the trapped bowel from the uterus under direct visualization. Comprehensive inspection. So it is important that we inspect the entire length of the small and the large bowel from the ligament of Treats to the rectum. We might have injured any other segment as well. Check for mesenteric hematomas and evaluate the blood supply to the affected segments. Uterine repair. Repair the uterine perforation with absorbable sutures, and at that point of time, if you feel that the abortion was incomplete, the remaining products of conception should be removed under the direct visualization or via separate hysterotomy if necessary, not from the same perforated scar. Bowel repair. So if there is a minor injury, primary repair in 2 layers perpendicular to the lumen using 3O absorbable sutures. If there is a major injury, if it is devitalized or the injury is extensive, there has to be performed a segmental resection with the primary reanastomosis. And for the major injuries, always consult a general surgeon or trauma surgeon for the surgical repair. Irrigation and closure. Copiously irrigate the peritoneal cavity and ensure meticulous hemostasis before the closure. So, what are the explanation? What are the clinical synthesis? This is called the bowel in cervix emergency. It is a catastrophic failure of the uterine body. So the primary goal is to minimize secondary injury. So mechanism of the secondary injury. So what happened was the primary event. Now we need to at least stop the secondary events going on. Traumatic traction is the greatest risk once the bowel is grasped. Pulling the bowel through the narrow uterine perforation and cervix can strip the entire mesentery, leading to ischemia and delayed necrosis, even if bowel wall appears intact. This is why immediate cessation and surgical release from above, that's the laparotomy, is safer than pulling it back from below. From below, when you're doing a D&E, it's a blind procedure. You don't know, you cannot see what's happening, and there's bleeding. You don't try to push that bowel back. Just stop the procedure right away. Surgical reasoning. A systematic running of the bowel is mandatory. Surgeons often miss a second injury site because they focus on only the segment that was involved and that they see in the cervix. What is the analogy behind it? Imagine if there is a thread caught in the zipper. If you pull that thread from the outside, you might pull or break the whole entire garment. To fix it, we always open the zipper, that's laparotomy in this case, and then carefully unhook the thread from the teeth. That's the uterine perforation, to see where the damage started. One of most important key points in this case would be, how should you complete the abortion before starting the laparotomy? No. The answer is no, never. Never attempt to continue the procedure if there is a perforation. The immediate priority is stabilizing the bowel. The abortion can be completed under direct visualization once the abdomen is open and injury is controlled and patient is stabilized. What are the signs of bowel devitalization? What are the signs when the bowel starts to get necrosed? There will be loss of peristalsis, there will be dark or dusky discolorations, that's cyanosis, absence of the arterial pulsation in the mesentery, and the failure to bleed when the serosa is nicked, so there is no blood flow there. And when should the general surgeon be called? A general surgeon should be involved whenever there is a full thickness luminal injury, signs of mesenteric ischemia, or if a resection or reanastomosis is required. So this was all about managing a patient who's undergoing a DNE and has a uterine perforation and a bowel injury as well. Thank you guys for watching this video. Please comment down below if you like the information and if you want me to cover any other topic. And please don't forget to like and subscribe. Dr. V, Sono to Gynae, who is preparing for her RCPSC exams. Follow along if you're giving some exams or you need some extra information or Canadian guidelines. See you in my next video. Bye.